Dr. John Marshall. Tell me a bit more about the background of this event.
Okay, well let me take you back about 20 years, because in fact it is something that has been evolving over time. In 1989, a group of Canadian intensive care intensivists, people who practice intensive care, got together with the idea of developing a group to promote investigator-led research into the optimal care of critically ill patients. And that group was called the Canadian Critical Care Trialists Group. It started as a group of about a dozen people. Today it's a group of over 300 people. It's been phenomenally successful in the sense that we have not only initiated our own studies, but they have been published in the very best journals, and they've really fundamentally changed critical care practice. So that model was taken up by a number of other groups. The second group to kind of adopt it was a group in Australia and New Zealand, and today there are probably 15 to 20 investigator-led clinical trials groups that focus on critical illness. Very similar kinds of structures, in some ways very different operating approaches in others. But
they share the kind of network research approach that you have different professionals in different areas, perhaps even dealing because of geography with different cases and different patients.
Exactly.
Sort of correlating that all into a larger view.
Right, and one of the things they share is they're practicing intensivists. So the questions they ask aren't, how can I get this new molecule to market and make a lot of money for it? They are, should I even be using this in the first place, or can I get away with less, or I really don't know what the best way to use this technology is. Some people do it this way, others do it this way. And that's part of the strength of it, is that we're asking the questions that investigators are interested in, which is a very different model from the bulk, not the bulk, because in fact it's probably the more dominant model now, but the more prominent kind of research, which is pharmaceutical company, device company that say, look, we've got this new tool that we want to try to establish a market for. How do we build it?
There's no sort of explicit outcome. It's more really dealing with the needs of care and dealing with the sort of pragmatic needs of care.
Exactly. And another thing that's quite neat about that is that it's not just doctors who are interested in this. It's nurses, physiotherapists, respiratory therapists. So in fact, all of our groups are a mixture of healthcare professionals, and even the act of participating, collaborating in research actually succeeds in breaking down a lot of the somewhat artificial professional barriers that exist on a day-to-day basis.
And legitimately reaching that kind of transdisciplinary research.
Exactly.
That's more than interdisciplinary, because you're getting all those different perspectives.
Exactly. And I think one of the things that's been both a key to our success, but also maybe a measure of some of that success, is that all of these groups have kind of adopted the model that when you get together to discuss good science, you do it as friends in places where you spend a lot of social time together. You intentionally set time aside in the middle of the day so that you can go on hikes or go skiing. You set time aside at night so that you can, have good meals, you can dance, you can have a lot of fun together. And again, it's a different model from the model that says, let's have it in the most efficient place, which is an airport hotel, and if we get through our agenda, I can catch an early flight and I can be home sooner. So it
recognizes the sort of human need to think creatively, to problem solve collaboratively in relaxed settings.
Exactly right. So as those groups have been forming, we've been having discussions about getting together to look at what our common needs are. Big need being getting funding, because there's not a lot of money available for this kind of thing. Other needs, though, being how do we come up with common metrics to describe what we're doing? When do we measure mortality in the ICU? How do we measure organ dysfunction? That sort of thing. How do we function? How do we make decisions? How do we raise our profile? How do we optimally deal with ethical issues? Because we're studying patients who can't provide consent on their own, and there are very, very different models to that. So we have had some discussions that go back to really about 2005, 2008, and then in 2009, H1N1 struck. And it became very quickly apparent that if there was ever both an opportunity and a need for us to collaborate, it was this emerging global pandemic, which at the time it appeared, there were legitimate estimates from organizations like the WHO that this could lead to a need for ICU beds for 10 to 100 million people.
And that it would just exceed the capacity.
Yeah, and it wasn't there. It had that happened, we couldn't have handled it. So we realized there was a need to actually understand what was going on and to try to see if we couldn't, during the pandemic, study to determine what the best way of treating patients were, both to optimize individual patient outcomes, but also to maximize the efficiency of the resources that were being used. And so we launched this program where we brought together very quickly about 20 different groups who all agreed to collaborate on a common program. We set up a number of different databases that actually became the first source of information for what the pandemic actually looked like. And it was all very exciting, except by the time the things were in place, the pandemic had pretty much run its course. And so the clinical trials we developed only recruited a couple of dozen patients. There were 3, one in France, one in the United States, and one in Canada.
But still, I assume, a worthy exercise in capacity building.
Absolutely.
Of going through the motions.
Absolutely.
If something were to be, a similar pandemic or
exactly
a similar crisis.
Exactly right. So coming out of it, a number of people in the InFACT, and InFACT stands for International Forum for Acute Care Trialists. It's the kind of network group that is trying to bring these different groups together. A number of people said, well, look, a lot of what we did, we could have done before the pandemic. We could have actually developed the protocols. We actually know the questions we would want to ask during a respiratory pandemic. Why can't we actually have this stuff done in advance for the next pandemic? So that was a very, very neat, innovative kind of idea. At the same time, public health agencies like the Public Health Agency of Canada said, look, it seems to us a lot of this information could have been pulled together in advance of the pandemic. Can that be done? And equally, a group of international funders who modestly call themselves the HEROES, and HEROES stands for Heads of International Research Organizations. They're kind of a group of 17 different large funders, so the Gates Foundation, the NIH, the Wellcome Trust, CIHR in Canada. They had been meeting last summer, and in part stimulated by H1N1, to talk about what were the priorities for global research collaboration. And they came up with a long list that included everything from understanding animal reservoirs for new viruses to understanding the optimal treatment of severe respiratory infection. And they decided hands down that the optimal treatment of severe respiratory infection was their priority. And so with the Wellcome Trust, they've championed the idea and they've developed a consortium called the International Severe Acute Respiratory Infection Consortium. So you have these 3 different people, all groups, all of whom are sort of moving in the same general direction. And what our meeting, which is planned for 10 days from now, I guess, hopes to do is to coalesce those on a global plan that would, in our case, specifically focus on the sickest patients, those who get admitted to an intensive care unit, but will bring together policymakers, funders, and investigators from these different groups around the world.
Well, and within that broader context of capacity building, I mean, it sounds like this is really the framework for how to deal with these types of crises, both on sharing research and data, but also understanding it, also getting a handle, especially for policymakers, in terms of how this impacts the broader society.
Exactly right. And so, the other trigger for this was SARS, of course, because SARS, we were all kind of caught by surprise. H1N1, we had a bit of experience from SARS, but again, you realize when you're caught in this that it's a huge issue. One of, I think, the really useful insights, and this comes from one of the people associated with Wellcome Trust, has been that the focus here is not the next pandemic. It's right now in the interpandemic period, and how do we put together both the structures but also the different ways of thinking that will enable us to do this at the same time. So these different ways of thinking are such things as it's not an individual who does a study, it's a group, and there may be 500 or 1,000 people. Challenges with that. How do you acknowledge the contribution that people make when you're talking about a large consortium? But it is a model that is beginning to be used in large genetic studies, where there will be large studies. Physicists do the same thing. There'll be
that just
hundreds of
requires so many participants in the research study.
Right. That you have, this is big research, and it can't be,
One
Dr.
guy.
Flo,
Yeah.
who did the whole thing. So they've really put a lot of emphasis on that. The other thing, and this is a big part of the reason that we're interested in your engagement in this, is that clearly social media and novel mechanisms for communication are a very, very powerful tool to enable something like this. For example, one of the ideas that we've had coming out of this is that ICUs potentially can serve as a sentry for warning of the emergence of new pandemics.
Sort of the front lines in broader public health in a radar sense,
Exactly.
rather than just a service delivery sense.
Exactly. So meteorologists have multiple weather monitoring stations set up all around the world, so that in a single area they know what's happening with the temperature, with the wind, with precipitation, and they can integrate this to predict what's going to happen 2 days from now and to provide you with a global picture of the weather. So we're thinking that the meteorological weather stations can in fact be intensive care units, so that if somebody says, listen, we've had strange over the last 2 days, we've had 3 people with something I've never seen before, they can hook up with somebody else who's maybe 100 miles away and says, that's interesting, we've seen the same thing, and we will much more quickly see how new problems are emerging, where they're emerging. And obviously things as simple as Twitter could in fact be a very powerful tool for allowing that kind of dialogue to occur.
Well, and clearly also speaks to the sort of globalized nature of things like our food supply.
Yeah.
That tainted food, you want to find it as quickly as possible.
Yeah, exactly.
And it may exist in multiple markets, that this allows for that intercommunication to resolve.
Exactly. And there are so many sources of information. So one of the people who's speaking at our meeting published a study showing that the emergence of the H1N1 pandemic could be predicted and tracked by patterns of air travel. And of course that makes sense, because SARS, certainly, you can map out how SARS evolved by knowing who was on a particular flight that left Hong Kong and where they went to. And that's how SARS left China and made it to the rest of the world.